Our next speaker is Dr. Yvette Miller, whose research expertise is in assessing maternity care performance from a consumer perspective and evaluating large, innovative health service reforms, behavioural epidemiology, and community-based maternal and infant health promotion. With colleagues from the University of Queensland, she helped establish the Queensland Centre for Mothers and Babies in 2008 and leads the Having a Baby in Queensland survey program. We're very lucky to have her. Oh, please welcome Yvette.
Thank you very much for the invitation. It's always a privilege to come and talk about what women have shared with us as part of the Having a Baby in Queensland survey. So I'm here today to talk most specifically about women's experiences of care in Metro North, using findings from the Having a Baby in Queensland survey. We did hear the Minister talk earlier about the importance of collecting evidence for the benefits of expanding the different options that are available to women. And I guess our work, particularly in the centre, is based on the assumption that we can't really know how well we're doing unless we ask women themselves, and that we do need to ask them about the aspects that they think most determine the overall quality of their care. Hang on. I'll work it out. Okay, so today I'm going to specifically talk about what we know about the quality of care in different models available across Metro North, and also a little bit about the processes of decision making about model of care using data from the survey, which is all about women's perspective, and I am going to use data that's specifically from women who completed the survey and had birthed in Metro North facilities. Just a little bit about the survey itself. We've conducted them so far in 2009, 2010 and 2012, and it is the 2012 data I'll be talking about today. We sample about a third of all birthing women in any survey year, and we invite them from the Registry of Births, Deaths and Marriages. So the survey is conducted independent of the health services that we're asking women to evaluate. We invite them to participate by mail, but they can complete the survey in a number of different ways. We invite them at about 3 months after their birth, so they are reporting retrospectively on the care that they received. And we do ask them lots of different questions about pregnancy, labour and birth and postpartum care, both in their birth facility and after they're discharged or return home. For the 2012 survey, we had a 30% response rate, which does concern a lot of people, but in fact it's the representativeness of the sample that's most important. And for the 2012 survey, our sample was largely representative of all birthing women in Queensland in that year, with the exception of underrepresenting Aboriginal and Torres Strait Islander women, and also women who were less than 20 years old at the time of their birth. We use women's reports across multiple aspects of their care at all stages, and we also use reports from each facility about the models of care that they provide and provided at the time of the survey to derive these particular categories for the model of care that women received. So if you have a look through there, I'm not going to go into them. Most of you are familiar with some of the definitions and lots of people are going to talk about them today. But our particular categorisation is primarily based on care provision in pregnancy and the place that women birthed. So here are the proportion of women in each model of care across Queensland and the proportion of women in each model of care in Metro North specifically. So you can see here that women who did the survey in Metro North were more likely to receive public midwifery continuity care than women across Queensland, and slightly less likely to receive GP shared care. Remember, this is data from 2012, so things may have changed since the data was collected. There are some features of continuity models that aren't necessarily well accounted for in the model of care categories that we use, like having one person who's responsible for coordinating your care, and also having continuity of care from pregnancy into intrapartum care or labour and birth. So when we look at these aspects that women report in each of the models, we see that women in private obstetric models were most likely to say they had one person coordinating their care. So that's comparing the size of the green bar with the size of the blue bar. This is for Metro North specifically. And we have similar proportions of women in private obstetric and public midwifery continuity models who said they had a known care provider in their labour and birth. So that's looking at a comparison between the size of the purple bar with the size of the blue bar there. I should point out here that we have very low rates of women in the survey who had private midwifery care, which means that unfortunately we cannot directly compare the other outcomes that I'm going to talk about today across the models of care for women who actually received private midwifery care. We need another survey to be able to do that, specifically asking women who received that model, and I think that would be quite a contribution. So this particular slide shows women's overall ratings of the quality of their care for women in each of the different models of care and during each stage of their care. So you can see their overall rating of the quality in pregnancy, in labour and birth, postpartum care in their birth facility, and postpartum care after discharge. And you can see here that high quality care was highest and about the same for private obstetric and for public midwifery continuity models in pregnancy, in labour and birth, and in postpartum care in the birth facility, but it was highest by quite a long way for postpartum care after discharge, as you might expect, for women in public midwifery continuity models. So that's looking at the far right there. And you can see how much higher the ratings of quality of care were for women in that green bar, which is the public midwifery continuity models. I do think it is interesting here, though, to note the high rates of quality care in labour and birth for women who were in GP shared care models, even though, as I showed on the previous slide, very few women in those models had a known care provider in their labour and birth. I guess what that tells me is it might be important not to assume that models that don't offer every single aspect of continuity are necessarily inferior for women. As we've already heard many people say, and I think we'll probably hear again, it's really about the best match between a particular woman and the model of care. So this particular graph, I am going to show you a lot of graphs, shows women's ratings for specific aspects of quality of care in pregnancy and in labour and birth. So that's feeling confident in the skills of their care provider, feeling safe, feeling in control, and being involved in decisions about their own care. And what we see across the board here is that private obstetric and public midwifery continuity models do perform better in these aspects across both episodes of care. So I've got them there for women's ratings during pregnancy and in labour and birth. But the GP shared care models, which is shown in purple here, perform as well on some specific aspects, and interestingly again, better than standard public models and almost the same as public midwifery continuity models in key areas of labour and birth care, which was a little bit surprising. Such as if you look at women's confidence in the skills of their care provider and being involved in decisions about their labour and birth. So this is labour and birth care specifically among women who receive GP shared care. The important thing to look at though is you can still see quite a gap here between the top of any of those bars, even those that are performing best, and the 100% line at the top there. So even on all these measures, the outcomes were still far less than optimal across all of the models, and are quite concerningly low on some, particularly for the standard public models.